Okay, I'm going to finish up at least chapter 61, if nothing else. We may get started on 62. I may do a little bit of 62 so that we can have a few more questions for this exam. So how do we prevent post-op complications? This was slide number 34. And what could the nurse do to prevent post-op complications? We went over this in class, but I'm just going to review it again real quick. So preventing post-op complications, correct body alignment to prevent dislocation of a prosthesis if they have a prosthetic, monitoring vital signs, redness, pain, and drainage to prevent infection or to notice any infection, assessing the neurovascular status, so color, temperature, pulse, trying to prevent any kind of neurovascular compromise. We've got elastic stockings, TED hose, scuds, things checking the peripheral pulses, things to prevent DVTs. Then we have the use of incentive spirometer, deep breathing, coughing every 2 hours to prevent any type of respiratory infection. These are all things we need to teach our clients. We can tell them how to do it, but when we tell them how to do it and why they need to do it, they're much more likely to be compliant. All right, so stop and think. A client has had a total hip replacement. In order to prevent a dislocation, how would you want this client positioned? You have information here on box 615 on page 1062 of the book, so be sure that you review that. This is a serious complication. A hip dislocation would be a very serious complication. Things you never want to do. You never want to bend past a 90-degree angle. So this is a 90-degree angle. You don't want them bending forward. This is their back, these are their legs. You don't want them bending forward. So you don't want them bending over their knees. They need to be back or back reclined so that that hip does not go past shorter than this 90-degree angle. You want to keep the knees apart at all times. Keep a pillow in between the legs while they're sleeping. That also keeps alignment for the hips. So if you lay on your side, one hip, the hip that's up is obviously going to sink down. So you want to keep a pillow between the legs to keep those hips level. You never cross your legs. That can very easily prevent or cause a dislocation. Avoid bending forward while seated to put on clothes, pick up objects from the floor, anything like that. And be sure that you use raised toilet seats because, again, you can't sit all the way down past the 90-degree angle. So you use a raised toilet seat. Then when you go to sit, let's say this is my legs and this is my upper body, I'm standing and I can go to sit like this on a raised toilet seat instead of sitting, closer, shorter than that 90-degree angle. So what's going to be important discharge information to obtain from the client? We need to know who's caring for the client at home. Who's preparing meals for the client? The client is going to be ambulatory. Who's going to help them ambulate? What about getting to doctor's appointments? What about performing their ADLs? You can't just say, okay, here's what you have to do and send them home without knowing that they can actually handle that they have the means for this. So be sure that you look over that. See Table 61-2 for preventing post-op complications on page 1065 as well. Those are going to be important. All right, then we're going to move into amputations. So amputation is the removal of a limb. They occur as a result of trauma and or disease or disability. You have 4 types of amputation. You have an above-the-knee amputation. Above the knee amputation is an AKA. A below the knee amputation is a BKA. Then you have an above the elbow amputation and a below the elbow amputation. So an AEA and a BEA. Okay, methods for amputation. There are actually different methods that they can do an amputation. There are 3 methods. You can have an open amputation, a closed amputation, or a staged amputation. So open amputation is called the guillotine method or guillotine amputation. It occurs when the end of the residual limb or the stump is left open temporarily without any skin covering it. So this method is often used in cases of infection when they may need to go in and kind of irrigate or do dressing changes or things like that. Then you've got a closed amputation, which is also called a flap amputation. This is when the skin flap covers the end of the bone. This is your more common type of amputation, is a closed amputation. And then third, we have what's called a staged amputation. So this is oftentimes when a client has a severe infection or some type of gangrene, and basically it's a combination of the guillotine and the closed amputation. So they do the guillotine amputation first, followed by this closed amputation. So it's called staged because it's done in stages, the guillotine first and then the closed amputation. Once the infection or the gangrene or whatever has healed and cleared, then they'll go in and do that flap amputation. All right, arm amputation. Clients with arm amputations, especially the arm with the dominant hand, require both physical and emotional support during the pre-op and post-op periods. It can be a really difficult, well, any type of amputation, but especially your dominant arm or dominant hand. That's very, very difficult. All right, leg amputations, a temporary prosthesis can be applied immediately after surgery to promote that intact sense of body image. All right, it also can help facilitate early ambulation. We do that. So an above the knee amputation is more disabling than a below the knee amputation. Unless the knee cannot be saved, every attempt is made to amputate below the knee, always first. Okay, complications of amputation include things like, hopefully you're looking in your book and finding these answers, pausing the video so you can find these answers. It'll be better for you in the long run. But the complications include things like hematoma, hemorrhage, infection, osteomyelitis, phantom limb pain, depression is a huge one, body image disturbance. These are all significant complications. All right, before a prosthetic can be made, the stump has to shrink and be shaped. So this is done with elastic bandages, mainly for leg amputations, as arm amputations often don't need shrinking. Okay, but there's a lot of information in your book about this as well. Phantom limb pain. People feel that they still have limbs there, whether they do or don't. They still feel it's very real to them. It is a very real pain, so you need to be sure that you address it as such. Right, phantom limb pain occurs after a limb is amputated. The client has sensation that the amputated limb is still there and can cause quite a significant amount of pain. It is very normal and occurs very frequently. It is sporadic in nature and can occur for months or decades. I mean decades. They can live with this pain for decades. It's very hard to cope with. The client may feel a burning, tingling, throbbing, or itching in the missing limb. So you definitely need to medicate for pain. When patients are complaining of pain in a limb that doesn't exist, that nerve ending is still there and it is still sending signals to the brain that it is painful. You do still need to medicate even though the limb is not there. All right, they may eventually require removal of nerve endings at the end of the stump. The pain can be a serious problem for emotional status, as well as their ability to use a prosthetic device. If they're having so much pain, they may not even be able to use a prosthetic device. So there are nursing guidelines 61.5 for stump care and bandages on page 1069. Please be sure that you look over that and read that. I'll probably have a question or something about that. All right, care and concerns. You have an adult client. Let me do this. Adult client with an AKA who is 1 day post-op above the knee amputation, 1 day post-op. What are the potential major concerns with this client? What would you do to prevent complications? If a complication does occur, what interventions would you need to perform? So hopefully you will take some time, pause the video, look through your book, and actually find these answers on your own. I'm going to go ahead and tell you what I have as far as my notes, but the concerns are going to be hemorrhage. You must keep a tourniquet at the bedside at all times for an amputation patient. You also want to elevate the stump for 24 to 48 hours to prevent any more significant edema. A slight Trendelenburg position. I hope you guys remember what Trendelenburg is. If not, look it up. So a slight Trendelenburg position. They do not recommend using pillows to elevate the stump. Now, why would that be? Again, hopefully you guys will look this up. But the reason they don't recommend pillows is because pillows promote a bending at the hip, which can lead to muscle contractures. So we may be doing one thing to help, but in the long run causing a second problem. All right, the same client is now 4 days post-op. And what are some complications with the client now, and how does care differ? All right, so complications, phantom limb pain and infection are going to be big complications. The care is going to be trying to get the patient to eat a nice, well-balanced diet, increase in their protein, trying to prevent any excessive weight gain, because then we may get this prosthetic leg, or well, generally a leg, and now it's not going to fit because now the client's put on too much weight. We're going to continue to monitor for infection, fever, chills, productive cough, any purulent drainage, new or different pain that the client experiences. The client may feel more mobile, which is a good thing. That's what we want. But you also have to monitor for injury. They may not be able to manage the prosthetic as well as they think they can. So you need to really be careful about that. Prevent respiratory infections by doing deep breathing until the patient is fully mobile. And follow any physician instructions for weight bearing. You know, the goal is for weight bearing, but it may be that they want to start off with weight bearing for just a few hours a day. Okay? Bandaging. Be sure that you look that up in the book. But you need to remove and rewrap twice a day and at bedtime to prevent basically cutting off the blood supply. You know, we've got to rewrap that twice a day and at bedtime. You need to keep the joint in a neutral position. And you want to avoid any kind of circular turns with the bandage, as this can promote or it can interfere with the blood flow and again cut off the circulation. So be sure that you review that on those pages on how to wrap, how you want to do the actual prosthetic wrap so that it's beneficial for the patient. Okay, moving on to chapter 62. I think I will actually just start a new PowerPoint for, no, I'm not. I'm going to keep going. I want to get through the first little bit of 62. I don't think it's going to be too much for you guys to handle for the exam. This is Thursday. I'll get this posted tonight. That still gives you all weekend to be able to study. So, did I make this go away? I'm not going to get too far into it, but I think I will go through just a little bit here. And then I'll finish it up next week and do chapter 63, which I'll probably have to record some of that also because that's a lot of content. And then we'll do P's the last week. And that's it. That's all I got for this group. All right, chapter 62, caring for clients with traumatic musculoskeletal injuries. So strains, contusions, and sprains, you need to know the difference. We're going to go over it, but there is a difference between a strain, a sprain, and a contusion. Be sure you know it. I'm sure you all have all heard the acronym. In fact, I'm pretty sure I taught it to you in first semester, of RICE, rest, ice, compression, and elevation. It's one of those things that's good to always remember. Don't forget RICE. All right, strains are when you have an injury to a muscle when it is stretched or pulled beyond its capacity. This can occur from, again, hopefully you guys will pause the video, look these answers up. You'll remember it much better if you do. But strains can occur from excessive stress, overuse, or overstretching. Client will experience inflammation, localized tenderness, and muscle spasms. Now, a contusion, obviously, is a soft tissue injury resulting from a blow or blunt trauma. So this is more like your bruising. Contusions don't affect musculoskeletal structures. They're confined to the soft tissue. The client has ecchymosis, which is the bruising, or a hematoma, a collection of blood at the site of injury. So often applications of cold pack can help resolve some local pain and swelling and bruising. And contusions will usually resolve within about 2 weeks. Okay? Now, sprains are when you have an injury to the ligament surrounding a joint. So remember that a strain is an injury to a muscle and a sprain is an injury to the ligament surrounding a joint. So sprains are often the result of a sudden unnatural movement or of stretching of a joint. All right, wrists, elbows, knees, and ankles are the most often area of sprain. Sprain with the cervical spine is commonly referred to as whiplash. So we've all heard of whiplash there. Sprains are a common injury from falls or other accidental injuries. So the joint is twisted in a direction beyond its normal range of motion, and it's usually confined to the ligaments. In severe sprains, the chip of the bone to which the ligament is attached may become detached. Okay, at this point it becomes an avulsion fracture, which we're going to go over fractures as well, but that's called an avulsion fracture, the pulling away of a fragment of bone by a ligament or tendon at its attachment. So I think I've told you guys this story before, but a couple of years ago, I don't know, I have injured both of my feet within the same year. I did one foot in April and the other one in September of the same year. So the September think it was the September one. I was out on the soccer field, because you know that's where I live, and I was walking along the sidelines, and there was a drainage hole that was not covered or anything. And so I was walking over to do something, and I stepped in that stupid drainage hole. Of course, I had flip-flops on because it was summer. And I stepped in the drainage hole, and my foot just kind of went, it just bit right over. In the process of that, what happened was it tore a ligament, which in turn chipped off a bit of the bone. So I ended up having an avulsion fracture, got put in a walking boot. Of course, my foot swelled up and was in a lot of pain. Got put in a walking boot for a while, went to PT. Couldn't hardly stand to do the PT. I was not getting any better, so I had to go back to the doctor and get casted for a couple of weeks. 4 weeks, I think we did the casting to try to help let that ligament try to heal a bit on its own, and then we went back to starting PT. And honestly, I didn't even know that I had done this avulsion fracture till several years later, when I went and was still having problems with my feet and everything else, and I went and had another x-ray done, and they were like, oh, have you ever had an avulsion fracture? I'm like, well, I don't know, what's going on? Well, we can see it right here in your x-ray. A piece of the bone is chipped off. And I was like, oh yeah, I'm sure that's probably when it happened. All right, assessment. Assessment will reveal acute pain and swelling. The client will most likely be unable to bear weight or use the injured extremity. The x-ray will reveal a larger than normal joint space and can also rule out fracture. So this did happen. I was in excruciating pain. It was a Saturday. I was supposed to work that night, and I could not walk. I had to call into work and tell them I couldn't come into work because I couldn't even walk. And like I said, I was on the soccer field. You know, you're not supposed to drive your car on the soccer field. That is like the biggest faux pas. You cannot do that. But I could not get back up to the car. So my husband had to drive down onto the field to pick me up. It was a mess. All right. Rice. Sometimes it's called rices. Treatment. Rice. We already discussed it. Rest. Ice. Why do we do ice? We do ice to reduce the pain and swelling for 24 to 48 hours. When you tell patients to apply ice, you need to be sure that you specify ice for 10 to 20 minutes at a time of every hour. Not for the whole hour, not all day. 10 to 20 minutes for each hour. That's going to leave you at least 40 minutes without ice or anything on. You never want to leave ice on longer than 20 minutes. Frostbite can easily occur within 45 minutes, and after 48 hours, generally you want to switch to heat. Now, what does heat do? When you apply heat, it's going to cause blood flow, increase the blood flow, because the blood flow starts coming to that heat source. It really opens up the blood vessels, dilates, vasodilates. So it improves that circulation, relieving edema and helping promote healing. Then C is your compression. This is why people usually wrap their foot or ankle or whatever with an ace bandage. Elevation, propping it up, and stabilization, maybe a splint or something. We can also have NSAIDs used to relieve inflammation, but they can cause GI upset, so we have to be sure that we warn our patients about that. There can be continued trauma during the healing phase if the joints are unstable, okay? You have to be really careful with this. I see a lot of kids out in soccer teams and such, and they'll say, oh, they're just sprained, they've just got a sprained ankle, and they wear a brace, and they keep on going, and they may have that brace on for like 3 seasons, and I'm thinking 3 seasons back to back, so pretty much a year and a half wearing a brace, an ankle splint or an ankle brace, and you know that obviously means that is not healing. It is not getting enough rest and causing further damage to the area. So you just need to be sure that you educate your patients on that. Okay, let's do dislocations here. This is a shoulder dislocation. This ball right here should be up here in this socket. So you can see that this shoulder has been dislocated. All right, dislocations are a separation of bones from the joint, interferes with normal use. It gives the patient a distorted appearance and can interrupt the blood supply to the structure. So that's one thing you have to be very cautious about, is checking peripheral pulses and making sure that they have a good blood supply below the dislocation. Dislocations occur when the articular surfaces of the joint are no longer in contact. So in adults, most commonly dislocations are caused by trauma. Okay, don't just happen. Something happened to cause the trauma. Let's see, the shoulders, hips, knee, and knees are more commonly affected joints, and a partial dislocation is called a subluxation. So a couple years back, my kids were on a swim team, and we were at swim championship, swim off, whatever. And this girl was swimming. She was a year-round swimmer. We just were swimming. I mean, she was swimming for the local pools, but anyway, she was a year-round swimmer. And she was swimming, comes right in, and swings right into the wall to touch the wall, because that's what you have to do to get your time counted. Touched the wall, and that force dislocated her shoulder, and she shot out of that water screaming, and it was obviously, I mean, you could see that it was very dislocated, and she was in a lot of severe pain. So, I mean, her parents happened to be right there. They were doing some of the timing as well. Of course, they gathered her up, took her straight to the emergency room, but it was just something as simple as that. I was watching one of those trauma shows, and a guy had actually had a hip replacement. It was a young guy, but he had already had a hip replacement and decided he needed to get back to the gym a little too early before the physician had recommended, and he went back to the gym and dislocated his hip again. All right. So you've got to be sure that you follow physician's orders and realize that these can happen in everyday situations, like this girl swimming. You know how many times she has swam in and hit the wall to get her time? Probably 1 million. But that one time she hit the wall, and it just, that force of it dislocated her shoulder. All right, an assessment will reveal that the client's structural shape is altered. It will look different. The client will have a depression noted around the joint circumference where the bones below and above are no longer aligned. So in the shoulder, you will definitely see where you can tell where this ball and socket meets. There'll be a deep depression right here where it's no longer meeting. The patient has pain and decreased range of motion. The client may have cooling, swelling, numbness, tingling, and pale or dusky color of the injured extremity, and you need to be really cautious with that. The patient with the dislocated shoulder, the affected limb, so if like the girl who dislocated her shoulder at the pool, because there's this depression and this joint is no longer together, the affected limb, so that arm that she hit the wall with that dislocated is now longer than the other arm. Okay? Patient is usually very anxious and screaming in pain. They often complain of hearing a popping sound when a dislocation occurred. And I don't know if I can't even remember the movie now. Oh, I do know. Here Comes the Boom with Kevin James. And he tries to be a boxer to save his school, and in the process, anyway, he dislocates his shoulder, and the school nurse goes, "I've never really done this, but I've seen it on TV," and she tries to do it, and sure enough, she sets it back, but it's very painful, very painful. Another movie, Lethal Weapon, that's an oldie for you guys, but Lethal Weapon, the guy dislocated his shoulder all the time, and he would go and jam his Mel Gibson. He did something like jammed a shoulder into the wall, and it would set it back in place. But that would have to take a specific type of dislocation, because generally you have to pull down to get it back up into the right spot. The physician will manipulate or reduce the joint into the normal position, and then they will immobilize it with an elastic bandage, cast, or a splint, so that the healing can then take place. Patient most likely will need moderate sedation. The nurse is responsible for placing the client on a cardiac monitor, giving them O2, obtaining vitals every 5 minutes while they're sedated, and making sure that there's an ambu bag at the bedside related to the sedation. The most often used drug is propafenol because it has a very quick half-life. All right, the nurse should administer the prescribed analgesics, elevate and immobilize the injured extremity, and perform neurovascular assessments every 30 minutes for several hours. If the patient is then discharged home, the client and family should demonstrate knowledge and skill of checking the neurovascular status checks every 2 to 4 hours for 24 to 48 hours. Okay? Neuro assessments that show increased pain, decreased movement, absent pulses, increased numbness. These are causes for concern. You're going to need to call the physician. One thing that you may detect in checking these neurovascular status is called compartment syndrome. So compartment syndrome is a condition in which a structure such as a nerve or tendon is constricted to a confined space, affecting nerve innervation. So this can lead to a decreased sensation and movement known as What's a decreased sensation or no movement? That's going to be called a palsy, so it can lead to a palsy. If compartment syndrome occurs in an upper extremity, it may lead to what's called Volkmann's contracture, and this is in your book as well. And that leaves the client with like a claw-like deformity. The client's unable to extend his or her fingers and complains of pain, especially when trying to stretch out the hand because of that nerve constriction. What is the emergent treatment for this syndrome to prevent loss of permanent injury to the extremity? So I hope that you'll take just a few minutes to look in your book and read a little bit about compartment syndrome here and try to answer this question on your own. But the emergent treatment for compression syndrome is going to be what's called a fasciotomy. A fasciotomy is a limb-saving procedure where the fascia, or the layer of tissue, is cut to relieve pressure. And this is compartment syndrome. So you see this increased swelling, cutting off the blood supply here, and they go in and they do this fasciotomy. Medial fasciotomy, incision through the fascia, exposing the superficial posterior compartment. So I had a friend who was a runner. Well, she still is a runner, but when she was in college, I think, running, she ended up getting compartment syndrome. I don't know the whole story exactly. I just know one day I saw her at the pool and I was like, why do you have these lines down your legs? Because she's very fit and tiny little thing. And she said when she was running all the time, she got compartment syndrome. And so they had to do this fasciotomy and just cut these lines down both sides of her calf to relieve this pressure, to prevent basically blood loss, because there's so much swelling in there. To be able to save her legs, they had to do this fasciotomy. Now she's fine. It's amazing. Okay, I think I'll stop there and we'll do upper and lower extremities and however far we can get for the next test. So for this test, Monday the 30th will be chapter 61 and 62 until upper and lower extremity injuries. I'm going to mark that real quick so I don't forget. And I think that's it. If you'll have questions, please send me an email. I will be checking emails frequently. Well, I'm going to try to check emails as frequently as I can. So be sure and send me an email if you have any questions about this. Thanks.